after the nice birthday celebrations, I think we'll talk about BRAF inhibition in non-small cell lung cancer, agents, efficacy, side effects, and tips for selection. My first reactions when I first saw the topic was like, how to become rich in 10 days. I think Jay Mehta is here, who will tell us about how to become rich overnight in 10 tips, in 10 days. I mean, he's the only one I could actually make out. Rest all our medical oncologists not worth their salt. My second reactions actually went on to Shah Rukh Khan and Saif Ali Khan. There are women over here, but that was a movie called as Kal Ho Na Ho, 6 Din and something of that sort in. My subsequent reactions in BRAF in this was there is no elevator to success. You have to take the short steps and you have to take the stairs. Basically, there is absolutely no elevator to success. And we all know what Preeti Zinta did to Saif Ali Khan and Shah Rukh Khan in the movie Kal Ho Na Ho. So let's master the class on BRAF. I think he has already, Dr. Feroz has very eloquently spoken about the RAS, RAF, MEK, MAPK pathway in the cell proliferation. So again, any residents here still? Perfect, fantastic. So we have one and we have, fantastic. We have 3 people over here. Fantastic, great. So the cell's growth factor basically comes here. It basically binds to the receptor tyrosine kinase, and then RAS gets activated, then RAF gets activated, then MEK gets activated, then ERK1 and ERK2 gets activated. So some chocolate questions for you guys. The chocolate question, first one goes to the lady over there because she was there yesterday too. What is the full form of BRAF? And this is my reaction on this. कृपया मेरी तरफ मत देखिए, मैं आपकी कोई मदद नहीं कर पाऊंगा. Maybe Vijay Patel will be able to help you. I will not be able to help you. So the question goes to them. The guy is now looking down. Full form of BRAF. We are having a master class on that. Okay. The full form of BRAF is basically a rapidly accelerated fibrosarcoma kinase family. So that is, I also didn't know prior to the class yesterday. So, you're absolutely okay in not knowing that. If there's a BRAF, is there a ARAF, CRAF, DRAF also? Who said yes? Fantastic. So there is an ARAF and CRAF, there is no DRAF. So only A, B, C, RAF are there is no DRAF. So we know the mutations in BRAF basically are Tier 1, Tier 2, Tier 3. The Tier 1 are BRAF V600, Tier 2 and Tier 3 are useless. That is the one thing to remember on this. And V600E accounts for around 40 to 50% of all the mutations in BRAF mutant lung cancer. So tip number 1, not all BRAF mutations are created equal. Look at the NGS report, talk to your pathologist. I think Jay Mehta and everybody, NGS people who are there, please talk to them. Just don't look at BRAF and say, okay, fine, we are going to give you, dabrafenib or tramatinib or whatever. Talk to them. So again, a second chocolate question, and this time it goes to them. BRAF mutations have been reported in all of the cancers except colorectal cancer, thyroid carcinoma, ovarian serous papillary carcinoma, non-small cell carcinoma. Ovarian. And the lady will answer her from there.
So ovarian carcinoma.
Ovarian. And the answer is none of the above. Chocolate question, no? How can I give you a right answer on this? It has been seen in all the cancers. 30% of ovarian serous papillary cancers will have a BRAF mutations over this, and this is not a sahi jawab. I thought somebody will say that actually. In fact, FDA has approved in the last month basket approval as a tissue agnostic marker for BRAF mutant non-small cell lung cancer into any and every cancer. So BRAF mutation, the tip number 2 over there is test. There is no age predilection, there is no sex predilection, there is no smoking predilection. You test for BRAF in basically everything. Is there a co-mutations with BRAF and the others? So if you have a BRAF V600E, there is no EGFR AL cross expression. If you have a BRAF other Tier 2 and Tier 3, you may have a co-mutation with KRAS and everything. So that is something which is very, very important. That's a tip number 3. The Tier 1 BRAF V600E mutations do not have they are mutually exclusive. They will not have an EGFR AL presentation. So now that you know the problem, the answer is very, very simple. You just block it. You have a BRAF inhibition, you have EGFR, you block it. So you have 2 drugs over here. One is vemurafenib and one is dabrafenib. You basically block it. So BRAF basically gets broken over here. And this was basically tested. Again, this is a chocolate question for Vijay Patel and Ashay Karpe. This is for them. You have tortured me by giving a class at 12 o'clock over there for this thing. I need to get back to you. So what is the full form of vemurafenib? And if any of the resident answers it, I am personally going to take you on a lunch. Not to Vijay Patil Nashif. Any of the resident, open challenge. I'll take you to a lunch of wherever place you are. It's a mnemonic. Who said this? Very good. The lunch was only for the resident. What is the mnemonic? Absolutely fantastic. So this is basically vemurafenib comes from V, E is Vem, mutant is Mu, rafenib is Raf, inib. So that is how the vemurafenib actually got its name, and even the Roche people don't know about it. But that is where the vemurafenib actually came, and that is what Shakespeare said. So now let's look at vemurafenib. Vemurafenib was tried in 79% of BRAF inhibitors and 79 patients of V600E NSCLC. Overall response rate was 43%. PFS was around 5.2 months, and the median OS was 10 months. Similarly, dabrafenib, which is a BRAF inhibitor, was tried in 84 patients. Overall response rate of around 33%, PFS of around 5.5 months. Almost similar to what your half of what your EGFR first generation TKIs give you. So the medical oncologists and the patients feeling at that time basically that we want more. We don't want, who is happy with 5.5? So like Jai has got Viru, Munna has got Circuit, Sanju got Kamli. Even no comments on this. I don't know who got who. Who is them? Anybody from the resident side? Lalit Modi and Sushmita Sen. Okay, so that is why dabrafenib also got tramatinib. So dabrafenib basically is the one which blocks the BRAF, and tramatinib is basically which blocks the MEK. So if you have RAF, you will get the MEK may get hyperactivated. You block them. So it's like ek se bhale do. I don't know what is going to happen to Lalit Modi and Sushmita Sen, but that is 1 to 1 plus 1 2 story. So dabrafenib plus tramatinib was initially tried not in non-small cell lung cancer. This was tried in melanoma. And the Combi D trials basically found out that the efficacy was more and the incidence of squamous cell carcinoma was less. Why is it less? I'll come to it later. Now, again, after that, phase 2 study of dabrafenib and tramatinib in BRAF mutant non-small cell lung cancer. 3 cohorts. Cohort A is dabrafenib. Cohort B is pre-treated dabrafenib tramatinib. Cohort C is treatment-naive dabrafenib tramatinib. The primary endpoint was response rate, and it had a 68.4 response rate. Remember, it was 37% with dabrafenib. The PFS was 10.2 months. Remember, it was 5.5 months with dabrafenib. In the first line, again, you had a response rate of around 64%. Again, remember, second line 64%, first line 63.9%, something which is not seen with ALK inhibitors and EGFR mutant inhibitors. And the PFS again was 10.8 and 10.9. So, overall survival, this was published by David Plancard in 2021, and in this issues of JTO, what they basically found out was median OS in the first line was 17.3 and the median OS in the second line was 18.2 months. So tip number 5 is, unlike the other TKIs, available evidence suggests that whether you give dabrafenib tramatinib in the first line or in the second line, it doesn't make a difference. Absolutely, as long as the patient gets dabrafenib tramatinib, you will have a response rate of around 64%, a median PFS of around 10 months, a median OS of around 18 months. So this is what the non V600 mutations will be saying. So I told you tier 1, tier 2, tier 3. Tier 1 is V600E, tier 2 are non V600, tier 3 again is this. So vemurafenib was now tried in non V600E, and the response rate was exactly what I got in my Hindi marks in class 5, 0. So please have a look at, I need 4 more minutes. Please have a look at the histology report. Just because you have a BRAF mutation positive, please do not go ahead and give them vemurafenib tramatinib. If you give vemurafenib tramatinib to a patient of a tier 2 or tier 3 mutation, make sure you have a professional indemnity of at least 1 crore, because otherwise you will never get out of the jail. Or you are friends with Kumar Prabhash. Even he will not be able to save you at that. So tip number 6 is, beware of using BRAF or only BRAF inhibitors in non-V600E mutations. What can you give? You can give them MEK inhibitors. You can give them MEK inhibitors plus RAS inhibitors, but please do not give them only BRAF inhibitors. That is very, very important. Now, what about the latest sensation in town? and I'm not talking about Kartik Aryan, I'm actually talking about the immunotherapy. A lot of time people will ask about, okay, fine, you have an immunotherapy thing which is positive. What do we do? First line PDL1, 50% and all. Should we give immunotherapy, chemotherapy, or should we give dabrafenib, trametinib? So 3 studies I'm going to quote. Second line study, retrospective data. But if you see here, overall response rate in the V600E population was 25%. It was 33% in non-V600E patients. In the Italian expanded access program of second line nivolumab, you had only 1 patient who responded out of 10. 9.1% people responded. PD in 72.7%. That is exactly the kind of female following that I had in my college, and the one became the wife in the end. So it is basically 1 and 91. So in the Italian expanded access program, nothing happened. You know, I mean, you do not give nivolumab, and you do not give nivolumab to a patient of BRAF inhibitor. The third study is something as the most often commonly quoted, the immunotarget study. In this, you had a CR/PR rate of 24%. In the second line, the checkmate 17 and the 57 nivolumab study, this is exactly what you get, a response rate of around 24 to 25%, and a PFS of around 3.1 months. A very, very important thing is what is written, what is on the right side of your screen, that is PFS by smoking. So if you have a BRAF V600E mutant and it's a female non-smoker or a male non-smoker, please be very, very, very of using immunotherapy. And that's my tip number 7, that beware of immunotherapy used as a single agent, first line or second line, in a patient of BRAF V600E mutation who is a non-smoker. That's the tip number 7. So the side effect profile. So if everything seems too good to be true, there seems to be something missing. That drug is toxic. Again, as I was telling about lorlatinib yesterday, and thankfully Pfizer is not there. This drug is not gefitinib, imatinib, and stuff like that. Just see the first line. All patients had at least 1 AE of any grade. So if you have 65 patients in cohort B and 35 in cohort A, cohort B and cohort C, 98% of patients had a side effect profile. Pyrexia was the most common. SGOT increase, ST increase, ejection fraction decrease basically was another thing. The 2 most common important side effects of dabrafenib, trametinib basically are fever and a skin rashes. You know, you can have a cutaneous squamous cell carcinoma. So let's look about if you have fever. Now that's very, very important, because whatever 7-8 patients of dabrafenib, trametinib we have, once a patient gets fever, what do? If you have fever between 38.5 to 40, stop dabrafenib, give steroids. If you have, and continue trametinib. If you have fever above 40, stop dabrafenib, stop trametinib, and give paracetamol. So 38.5 to 40, stop dabrafenib, continue trametinib, and give paracetamol. First episode, once fever comes to normal, restart dabrafenib at the same dose. If it is a second event, then you may consider oral steroids. If it is subsequent events, then you dose reduce the dabrafenib. Please, I mean, Novartis has given an excellent sheet on dabrafenib, trametinib. Just put dabrafenib, trametinib, put a Google search on that. Excellent sheet is there on the website. And once the patient has fever, please use that. Now, fever is a class effect of dabrafenib and vemurafenib. So that's very, very important. It has got nothing to do with trametinib. So dabrafenib is the most important drug for that. And the tip number 9 over there is expect fever in the first 2 weeks. Dabrafenib is the culprit. Follow the guidelines. Just don't get a blood culture done, procal done, and everything done over there. The second issue, and that's my second last slide, just in case people are getting this thing to go. Concomitant use of dabrafenib, trametinib actually reduces the risk of cutaneous malignancy. And the question is, the thing is why? Because cutaneous toxicities are again common with BRAF inhibitors only, that is dabrafenib and vemurafenib. Why? Because it causes paradoxical activation of MAPK pathway in the BRAF wild type cells. So that is why you get more squamous cell carcinomas and other carcinomas. But if you combine them with the MEK inhibitor, you have an incidence of only 1 to 2% of malignancies with BRAF and dabrafenib trametinib combination. But be very, very, very friends with your dermatologist. Get a thorough skin evaluation done. Once every 2 months, 3 months, please let the guy come over there and be seen by a dermatologist, because if this guy has a secondary cancer, then even Kumar Prabhash and Vijay Patil and Ashay, nobody can save you over there and have a good BI at that time. So tip number 10, be friends with dermatologists, do a good dermatological evaluation. So this is a patient that we had of dabrafenib trametinib. This was the one at the baseline. She is a female non-smoker. We gave her dabrafenib trametinib. The lady has taken dabrafenib trametinib for around at least 16 to 18 months. Absolutely fantastic. Has got no side effects whatsoever, basically. So where are we in 2022 with BRAF V600E mutation? First of all, find out the mutation. It has to be a V600E key, D or R. If you detect it prior, and I'm a big proponent of giving dabrafenib trametinib in the first line, because if you don't give it in the first line, your first line is 65% response rate. Your immunotherapy is only going to give you 20 to 30% response rate. Then you give them platinum-based chemotherapy, IO. IO, I will avoid as a single agent if the patient is not a smoker. Female non-smoker, I will not give IO. Smoker and BRAF, whatever 600V or non-600V, you can actually go ahead with that. So to conclude, a journey of 1,000 miles actually begins with a single step. We have taken only a single step because, as Dr. Rakesh Penati will now tell you in his next talk, there are a lot of resistance patterns to BRAF inhibitors. And just to quote Robert Frost, the woods are lovely, dark and deep, but we have promises to keep and miles to go before we sleep and make BRAF somewhere in the league of EGFR and ALK inhibitors. So with this, thank you, and hope to see you soon next year. Thank you.
Thank you, Dr. Ullas. I mean, this is the reason why he was given this talk. You know, you can make interesting even any boring topic. And I think we have seen years because, you know, first of all, you have to have an understanding of the topic.
Vijay Patil is coming with a question. Nobody has been asked question. Vijay, this is not fair.
No, this is actually, how many times have you seen pyrexia after?
Oh, we have seen. We have seen. So in my 7 patients of dabrafenib trametinib, we have seen 3 patients.
Oh, that's good because in our experience, we are not seeing that much of pyrexia.
So we have seen in 3 out of 7 patients. And 1 patient we had to dose reduce dabrafenib.
So I think, thank you very much, sir. You know,
Thank you.
basically that's why I was just saying, understanding the topic and creating the other similes, you know, I think that's lots of effort. And I think you have some impact on Dr. Mansi Sharma also because she also had a wonderful presentation yesterday. So definitely being your colleague, I think she had that
Thank
impression.
you.
Thank you very much.
Or maybe
So-
it's the other way around. Thank you.